This is Dan Robinson. I'm talking to Shyan Vijayasekaran, who is a paediatric ear, nose and throat surgeon working in Perth at Princess Margaret Hospital. And he is fellowship trained with 2 years of training at Cincinnati with Robert Cotton. Today we're talking about vocal cord palsy. So Shyan, to start with, what are the causes of vocal cord palsy in the paediatric patient?
Well, the most common cause of vocal cord palsy, if you're talking about unilateral vocal cord palsy, is mediastinal surgery or cardiac surgery. Bilateral vocal cord palsy, the most common cause is a congenital idiopathic bilateral vocal cord palsy.
And what is the percentage of unilateral versus bilateral vocal cord palsy?
I think, so in my practice, it's probably something like 2/3 unilateral, 1/3 bilateral. And that's because of the significant incidence of unilateral cord paralysis in cardiac surgery, but also in surgery for tracheoesophageal fistula repair. So right for the tracheoesophageal fistula repairs and left for the cardiac cases.
When you see one of these children who has a unilateral vocal cord palsy secondary to a surgical cause, how many of these do you find recover spontaneously?
Probably 1/3 of the iatrogenic cases recover spontaneously, and the benefit of having a unilateral cord paralysis is that they're often minimally symptomatic in children. Occasionally they have aspiration and occasionally they present with dysphonia, but in general they're asymptomatic. Cases of idiopathic bilateral vocal cord paralysis is less likely to recover, and the time to recovery is variable. It can be anywhere between 6 months and some people have noted up to 11 or 12 years of age, and probably about 50% of these patients recover spontaneously.
So when and how do you investigate these patients with either unilateral or bilateral vocal cord palsy?
So patients who present normally get a fibre optic nasal endoscopy to make the diagnosis, and then they have full physical examination, history and so on. The children who have a bilateral cord paralysis, we usually perform an MRI scan of the brain, brainstem, neck and mediastinum. In kids who have a definite history of cardiac surgery who present, or any form of mediastinal surgery and present with unilateral cord paralysis, I don't normally investigate them with an MRI. And then all patients will have a microlaryngoscopy and bronchoscopy to evaluate their larynx and ensure there are no other airway lesions. And then kids who have nocturnal airway obstruction may get a sleep study.
In your experience, when you perform your LVO on these patients, how many cricoarytenoid fixations have you found?
There is a not insignificant incidence of cricoarytenoid fixation in children who've been previously intubated, and in fact did a cadaveric study with Robert Cotton as his fellow, and we found an association between the duration of intubation and the degree of cricoarytenoid pathology in neonates who've been intubated. So, and I think this is a really underappreciated problem in our community, and one of the reasons why laryngotracheal reconstruction for purely subglottic stenosis may sometimes fail because people fail to address the cricoarytenoid fixation. So it's not insignificant. It's hard to say what the percentage is, but there is a significant incidence.
And for patients with a bilateral cord palsy, can you describe your approach to the patient and then also when you consider giving them a tracheostomy?
So once you've done the aforementioned investigations, if a tracheostomy is indicated for airway obstruction or extubation difficulty, symptoms of stridor and respiratory distress, there are a couple of patients who I've recommended a tracheostomy because they've had severe obstructive sleep apnea due to their bilateral vocal cord fixation. And children who fail to thrive may also need some form of tracheostomy or a reconstruction to enable them to have a patent larynx. So I don't often go straight to a tracheostomy. I may actually offer the patient the option of an endoscopic or openly placed posterior costal cartilage graft as an alternative to a tracheostomy.
Do you feel that intervention of some regard, either costal cartilage graft or tracheostomy, is mandatory in patients with bilateral vocal cord palsy? Or do you think there's a role for conservative management in these patients?
Oh, there's definitely a role for conservative management. In my experience, and if you look at the literature, somewhere between 50% and 2/3 of patients, so half and 2/3 of patients with bilateral cord paralysis need a tracheostomy. And there are certainly children who have bilateral cord paralysis whose vocal cords sit in a paramedian position who have an adequate airway and do not require tracheostomy.
And you've already mentioned surgical intervention for bilateral cord palsy in patients. Would you be able to elaborate on what surgery, if any, you would perform on patients with unilateral cord palsy?
Rarely is surgery indicated in children with unilateral cord paralysis. The only time I've had to intervene is in in teenagers who present with dysphonia and breathy voice due to their unilateral paralysis, who failed voice therapy, in whom medialization procedure, either endoscopic or open, is suggested.
Do you consider using an EMG at all in patients with a vocal cord palsy?
I have toyed with performing an EMG, and I've done a few EMGs, but I don't find them that helpful. I know there are some clinicians who use them routinely to help guide their treatment, but it's not something that is part of my practice.
And finally, is there anything else which you'd like to add or elaborate on which we either haven't covered or you'd feel you'd like to further stress as a parting comment?
I think, the use of posterior costal cartilage grafting has been a revolution in the management of bilateral vocal cord paralysis in the pediatric patient. And the fact that this procedure that was pioneered in Chicago and then popularized throughout the US and now through the world has really meant that children with bilateral cord paralysis who have significant airway obstruction are not always treated with a tracheostomy, and can have a procedure that is relatively simple that can enable them to avoid a tracheostomy, yet have a good quality voice, have a patent airway, and swallow without aspiration.
Shyan, thank you very much for your time.
Dan, thank you.